Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as medical director of care management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussion surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations. Today we have selected two intriguing cases to discuss.
Hello, and I'm Teresa Jacobs, and I'm presenting the first case that we have today. And this case is a 57-year-old male with a past medical history of alcohol use disorder, tobacco dependence, psoriasis, which he's had on his shins previously, who had 3 days of rash that was painful. He came to an outside hospital where he received IV pain medications, and his clinical exam was noted for the rash that proceeds over his arms, legs, and torso and covers greater than 80% of the surface area of his skin. He's also noted to have significant lower extremity edema. So the outside hospital, which is a small facility, called our institution to transition the patient over to our hospital due to the need for a higher level of care than they felt they could justify. On admission, the patient here complained of pain. His vital signs did show an elevated blood pressure with systolic pressures in the 190s. His laboratory studies were notable for a leukocytosis with a left shift. And the skin exam did show the 80% surface area of the body covered with lesions that were red, non-blanching, with cracking and a small amount of bleeding in some of the locations. In our emergency department, dermatology was called in subspecialty consultation. They came and did a punch biopsy and recommended the patient admission for a modified Geckerman therapy. The patient was treated with triamcinolone to all the lesions on the body surface area and was placed for 4 hours into a sauna suit, which alternates 4 hours on and off. And he also had cortisone applied to the skin of the face, axilla, and groin on a BID basis. Laboratory studies, including basic coags and chemistry panels, were completed every AM and PM on a Q12-hour basis. The patient was additionally treated with zinc oxide, hydroxyzine every 4 hours. On his scalp, he was given a ketoconazole shampoo and a flecainide topical solution. He also had coverage for potential alcohol withdrawal syndromes. We put him on our MAWS protocol, which monitors for alcohol withdrawal and treats with benzodiazepines as needed, depending on the score of the patient. He was also provided with IV thiamine as well as a multivitamin with iron. For his lower extremity edema, the patient was initially given 40 milligrams IV of Lasix on the first day in presentation to the ED, and that was followed by 60 milligrams of Lasix on days 2 and 3 until his significant peripheral edema was resolving. Throughout his stay, the patient continued to have pain that was treated, pruritus, and lower extremity swelling, which was getting better by the third day of his stay. But overall, given the needs he had in his modified Geckerman therapy, he stayed a total of 5 days. His rash was improving, his pain decreasing. At the time we discharged him to home with his son, who was a caretaker, and the patient's case was then denied by the payer.
And Teresa, what type of payer are we dealing with here for this case?
This is a Medicare Advantage payer.
Okay.
So it would have been a Medicare Advantage plan. And it's more in the private marketplace. It's not Medicare.
Yeah, wow. That definitely sounds like an interesting case in terms, clinically. I guess this is one for me that since it's definitely out of my, scope of comfort for clinical practice. Like I do not feel like I'm a dermatologist. Rarely do I see anything in the inpatient space that, that relates to dermatology other than your bread and butter cellulitis and, wounds and things like that. So I think this is one for me. If I were thinking about appealing this, I might, if I couldn't tell from the notes, want to clarify a little bit more from my clinicians, like, what are you worried about? Like, I see they're doing multiple labs. I'm not sure from this sauna suit. I don't think I've ever had a patient with that. Were they worried about like fluid losses? Is there something, or was there a lot of oozing from the wounds that also added to that? Why the intensive monitoring in the hospital? I'm not sure. That just jumps out at me without digging into the notes. And, I know sometimes maybe it's obvious to that specialist, but that's where if I couldn't see them outlining what they're thinking in the chart, I would probably want to talk to them. And
I can tell you, Rebecca, we see a lot of this here at the University of Michigan. We have a big dermatology department, and as the Quaternary Referral Center, we see we used to see even more modified Geckerman being done within the hospital setting. There has been the initiation of an outpatient modified Geckerman program, but this patient had an 80% body surface area involved. So the things that they were concerned about when they bring these patients in are cellulitis or the development of an necrotizing cellulitis, which are big concerns for the patient, and also the intensity of services and the need for the constant monitoring, the application of various different medications to the skin surface, and as well as the laboratory studies to be sure that we weren't encountering any other new types of problems. So that's the justification that the dermatology folks will give us when we question them. In this patient's case, there was some bleeding from some of the lesions, but it was not severe. The oozing was not a lot, but there was definitely edema that is not typically present with most skin findings to the degree that this edema was present. And I wanted to bring this case to you guys because I think that as we start to, when we do these peer-to-peers or discussions of denials with the payer, I found it particularly helpful, if able, to provide visual evidence to them. Now, on some of our peer-to-peers, we are able to actually, on our Zoom calls, share. And I will make a PowerPoint slide presentation of what is wrong with the patient, either their skin, their x-ray, or their CT scan. I use it for brain tumor patients with diffuse cerebral edema or what have you. A picture is worth 1,000 words. We all know that. We all became doctors because part of us is very visual. So the lucky thing is that I was able to prepare a slide deck to send to the person I was doing the peer-to-peer with at the payer so that they could actually see what we were talking about here, which I think I'll get to cut to the chase to say that I argued the case because of the severity of illness, the potential risk of the development of cellulitis and necrotizing fasciitis, and the fact that there was such an intensity of services, and the pictures brought that home, the visualization of the degree of the body that was affected by this particular patient. Yeah, no, Sweta, have you had any cases where you've been able to utilize visual aids?
I personally haven't utilized any visual aids, but
like you said, we do get to take care of a lot of modified Guckerman treatment patients as a hospitalist here at University of Michigan. And one of the reason is that it's hard to do it now. We try doing it as an outpatient because they do it once a day. And the modified Guckerman that we do in hospital is twice a day. And for 4 hours, they have all these extensive, especially when they have a large body surface area, application of the topical steroids, and that to high concentration, followed by, and then put the sauna suit, put all the gloves to keep it retained. And when you have that much skin affected, there is high risk of topical absorption. And thus they increase the risk of blood turbulence and blood pressure. That's what we are monitoring them in hospital for. So giving that background, giving that explanation, again, this patient in particular, I think there's more to the story with that lower extremity swelling because not all our psoriasis patients have that and use of IV LASIK. So even if it was, say, commercial care, I would say we need to argue for complexity and more things that are in that are important in this patient care. For example, even the MOS protocol, which requires every 2 hour vitals and checking on the patient and as needed admin, even if they don't end up using a lot of benzodiazepine, but that constant checking and a lot of time requiring telemetry or remote telemetry for the heart rate is another utilization of resources that's important. So I just wanted to add. So how was so you were able to win this case, right? That was the outcome.
Yes, and that was with one of our most difficult payers. And I think I don't even need to say a name, nor will I here, but we have some, and we all have them, payers that are more difficult than others to really convince about the medical necessity of the patient's stay. And in this case, this was one of our more stringent set of payers who does not like to overturn any denial that they make. And yet, I think a combination of the medical necessity, the degree of utilization of resources, the photographic information that was presented to them, really by the end of the call that I had with them, and it was not a long call, they were pretty convinced that, yes, this patient, for all intents and purposes, did require an inpatient stay to be able to accomplish the goals of bringing them back to health.
Yeah, a couple of, as we've been talking here, I guess a couple of things popped in my head. And, one of them is just like my reaction, like I don't deal with patients like this. Like these protocols, other than alcohol withdrawal, and ours is just called something different. But, like these other protocols, I don't know what they entail. And so I think we have to assume too, especially if you are at a tertiary quaternary center and treating something a little bit more unusual, I think it's best to start off and make sure that other clinician at the payer side has that same foundational knowledge you do. Because to you, it may be quite obvious, but if they don't know what this treatment is, you may be talking, you may not realize they don't get what you're talking about. So I think that is helpful too. I agree, Teresa. I like the visual for skin things, even the cellulitis. I have not sent a picture, but I will oftentimes ask for my clinicians when I know I'm going to have to do a peer-to-peer, hey, could you get me a picture of that? Could you, or in your words, describe to me how bad this cellulitis looked? Like how far up the leg did it go? What, tell me about how it felt boggy and, and you were concerned about an abscess forming. Like I will get those details and try to, verbally paint that picture for the clinician, because I think too often, even your bread and butter cellulitis, I mean, there's those that are kind of mild and then those that are bad. And to be honest, a lot of notes, you can't tell the difference. Like, so that's where I oftentimes that coaching and, or a conversation with my frontline clinician to see what they're seeing at the bedside and try to convey that to the payer has been successful for me.
The other reason I brought this case to you guys for us to discuss is because I think nowadays, and I'm sure you're finding it too, Rebecca, that we get a lot of private payers who want to call something observation just because of the way it sounds, like cellulitis should be observation in their mind. even DKA or AFib with RVR has become something that is time limited and intensity limited in a short period of time, that they want to call it an observation admission. But a lot of these more difficult cases, I think we still need to have them step out of their boundary setting of what observation is to come over to the side to see just the intensity of work that is going on with these patients with a more severe form of whatever diagnoses they have. And that's what I feel about the modified Gackerman is that over time we're doing less and less of it. And part of that is because we're just not able to get them approved. But sometimes, like this, 80% of the body surface area, the photos were very, very telling. The lower extremity edema, the Moz protocol, they all combined. That was the alcohol withdrawal protocol. They all combined in the medical complexity to drive the payer to say, kind of uncle about, yes, we need to reverse this denial.
That seems very appropriate. So great case.
All right, that finishes my first case for this session.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acma.org/membership to learn more. Let's continue with our second case.
Well, I guess I will take over here with the next case. And so my first case, this one did have involvement on the front end by our physician advisor, but it's a 64-year-old male with Huntington's disease who's presenting to a facility with acute confusion, some weakness, and had some elevated blood sugars. Had rhabdo, some mild rhabdo, and some mild hyponatremia. Also, they checked somehow a respiratory panel and found the patient was positive for RSV. So this case initially was started as inpatient. It is a managed Medicare case. And then on hospital day 2, it was sent to our physician advisor. Our nurse was struggling to try to find, clear criteria on why this patient met for inpatient. So the PA at that point had opted to downgrade the case. Now, so the case did continue to play out after that downgrade. The patient continued to have some issues with hyperglycemia, with blood sugars in the 200 to 300 range. The mentation was a little bit slowed, and that's per the endocrine physician's documentation. Endocrine doc was still wanting to monitor that glucose, and it was making some insulin changes. They'd also kept that patient on IV fluids due to some poor oral intake. This case continued to become a subsequent, review for our team. On hospital day 3, the patient was having better hyperglycemic control, just a little bit, slowed, but otherwise nothing, too significant on hospital day 3. And then finally, in hospital day 4, the patient was noted to have a fever up to 102. And it did go back to our physician advisor at that point in time. I'm going to pause there and just see what are both of you thinking, like how this has played out, how it was managed by like our team. Any thoughts around this case so far?
Well, the Huntington's patients can be very difficult because oftentimes, as well as their underlying Huntington's disease, which gives them problems, they have medical issues that are separate from the Huntington's process and advancement of the disease. So whenever I heard you say about the encephalopathy, one conclusion I would think if I were the payer's medical director would be to ask, is this mental status changes or slowness, is that really just part and parcel of the underlying diagnosis of Huntington's disease, or is that related to the medical conditions that are also coming about by for this patient, like the hypernatremia that you mentioned? The hyperglycemia, maybe not so much, but there were a couple other things. And then the other question I would have about this, since you stopped there, that came to mind is this fever that you had on, I think you said it was day 4. And my question would be, with Huntington's patients, they also have behavioral issues and sometimes are given antipsychotics as a result of those behavioral issues. And so a question that will come to my mind is that, was the provider worried about neuroleptic malignant syndrome in the face of any kind of medication that might have been administered, like an antipsychotic? So when I start to see that this could be an even more complicated hospital stay than we were just looking at initially. And as far as the inpatient back to observation, back to inpatient, I think what it really does prove is that you guys are being very careful about trying to be sure that the medical necessity level is met to have the 2 midnight rule met. Sweta?
I like you said, initially, a lot of these like hypernatremia, hyperglycemia, if they resolve, which commonly they do with initial management, and patients are able to be discharged next day, are appropriate for observation. But someone with an underlying complexity and complex past medical history that is going to extend their hospital stay, it makes it hard. But blood glucose of 200 to 300 is not that high, so I can see why it was changed to observation and kept as observation. But I think here a little bit of the need for IV fluids, poor oral intake, I would then, and making adjustments to insulin, argue that we can change them to inpatient sooner than later. But it is hard to make that decision sometimes when you're reviewing the case on day 2, when things have started to look better, and then on chart, they will look like, oh, they're ready to be discharged now. It's just when you see that progress, nope, they're not able to be discharged because they're not eating and drinking much. They're requiring IV fluids. We're still adjusting the insulin and don't have a safe insulin regimen to send them home. And now a brand new fever. I think we have enough medical necessity, severity of illness, and utilization of resources that we can argue that we can convert them to inpatient now.
Yeah. And we did go ahead and upgrade. There was a denial in the case. And when the fever started, they did, even though the patient had the RSV, they did go ahead and cover with antibiotics because they weren't sure. But I think for me, one of the things that I saw when I forget how I got looped into this case from one of my physician advisors was, just that initial downgrade. I do find that it's this back and forth sometimes makes payers look at these cases a little bit differently. I think sometimes they come across their work queues looking like a shorter length of stay just because of when the inpatient order occurs and triggers them to review. But I think for me, the one thing that I thought of when, I was looking at, of course, retrospectively, it's always easier, was, in hospital day 2, this was, before we downgrade, and I know it had some, those, what I like call those soft, squishy diagnoses where, the weakness, they're a little confused, they're not quite themselves, you don't have a lot of hard objective numbers. It's just to pause though and find out, is the patient staying? Because I think before I downgrade a case, I really want to know, are they going or are they staying? And if they're staying and I'm not sure I know why they're staying, that is oftentimes the dialogue I have with my clinicians. Like, help me understand why the patient needs to be here. What are you worried about? And what can we get in the note? Because I think that is oftentimes, that's what will make or break your inpatient. And so I know if I'm recalling correctly now, I think one of my physician advisors had reached out to me and said, "Hey, I'm not sure if I should go after this one or not. Should I upgrade it, and should I go after the denial?" And I was like, "Yeah, I think you should have adequate medical necessity for the, justification of the 2 midnights, the oral intake numbers, the need for IV fluids. They're running at 150 cc's. You've got an underlying complex patient." I know, Teresa, I don't, I didn't, when I did the case, I didn't look for other medication side effects. I guess that wasn't the angle I took, but of course, with your neurology background, that's, that would have been a nice thought too. So I can't answer that question, but it definitely was one that, as we worked through it, we were able to get enough in the chart. We were able to get this one, overturned, and really tried to, focus in on that 2 midnight rule, why the patient needed to be here, what was that medical necessity. So we did get it overturned. But I think there was a little bit of a longer conversation with our payer on this one.
I think that, sorry about the noise in the background. I think you brought up a good point on both this case and the last case, Rebecca, and that is the one of actually reaching out to the primary physician who's handling the case. When we get several new PAs starting, that's one of the things we try to encourage them to do, is to go ahead and make that. My dog is stimulating your dog, is what probably happened. So I think that early on for the physician advisors, it's important that they make that leap of comfort in talking to the doctor who's handling the case primarily, because getting that kind of firsthand information, whether it be a descriptor of what's obvious in front of them, or the plan of attack that they have, or input they may have gotten somewhere else that might not appear in the notes, becomes very important to winning or having some of these cases overturned.
Yeah, and I completely agree, Teresa. I think too often, like, especially I'm a newer PA, I think that, they'll look at it and at first blush, they don't quite see the argument. And I guess having done this for a while, like, I'm like, ooh, I see a little hint of something. And I'm not afraid, I guess, to reach out to my clinicians and just ask them, what am I missing? And over time, I think, initially, I know some of my peers, like, I don't want to bother my colleagues, but I think, they too want these approved. So I usually will say, hey, sorry to bother you, but I have a denial. I just want to make sure I've got all the information. Can you, and I'll tell them what I understand. I say, hey, do you have anything else? Or I'll ask them pointed questions. And we make it to the, shorten to the point of what I need from them. And in general, I found that, my other clinicians are very receptive to that. I mean, rarely are they going to, like, get mad at you for asking, because they know you're doing the hard work for them. You're helping fight for their patients. So usually I find that they're pretty receptive to me reaching out.
Yeah, I understand. Whenever I was early doing this, I'm kind of assertive in picking up the phone and calling and talking to people. But some people just naturally are not that way. But it's really, I think, invaluable to understand what the bedside physician's seeing and doing.
Yeah, agreed.
And I think I can see some of the hesitation because bedside providers are busy, they're rounding, they take time to respond because they prioritize clinical work, and that sometimes gives almost like a negative feedback. The vicious cycle, okay, it takes me time, I have to wait, I might as well get to the determination and get to the next case. But key here is it's extremely important to have the direct feedback and input from the bedside providers, because at the end of the day, they are the ones next to the patient and can give additional information that may not be visible on the chart. And we can utilize this opportunity to also educate. Perfect. When you're telling me now, can you make sure to add that to your notes? Where we can make sure we have an improved documentation too.
Yeah, where we would never say to them, could you please dictate blank, blank, and blank? We would never want to do that. That's not what we're about. But having them explain something to us and saying, oh, if I would see that descriptor in your note, I think that would really help clarify it for me and possibly also to the payer. Then they'll understand that their documentation process could be improved, which is what we all are about.
Yep, definitely agree.
Thanks, Rebecca.
Yeah, you're welcome.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Doctors Severe, Singh, and Jacobs for sharing these interesting cases in this episode. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.